Everyone, thank you and welcome for joining us in this Research Connect series. My name is Jorge Castillo. I'm a CDTRP trainee and I'm a graduate student in the laboratory of Dr. Ian Rogers at Mount Sinai Hospital in Toronto, and I will be facilitating today's webinar. First of all, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dean, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, language, and cultures continue to influence our vibrant community. And I encourage everyone here to write your lang acknowledgement in the chat box. And we would also like to acknowledge Astellas, AstraZeneca, and CIHR, whose generous support enabled us to host these sessions. And before we dive into the main content, I'll pass it over to Erica for some general CDTRP updates.
Thank you, Jorge. Today I have one announcement for you all, and it's a save the date for our PFD forum. This year, Patient, Family, and Donor Research Forum will be held virtually on June 13th and 14th. Registration is free, and it can be done through the link in the chat box. Thank you.
And before I introduce the speakers or the speaker today, I have a few housekeeping notes. And so today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. And if you have any question or comment, you can raise your hand with the raise hand button or type it in the comment section. And today I'm pleased to introduce our presenter, Mrs. Chelsea Lanos. Chelsea is an Ontario-based advanced care and community paramedic, educator, and researcher. She is an adjunct lecturer at Monash University in Australia. She holds a master's in clinical care with a dissertation focusing on organ donation after out-of-hospital cardiac arrest. Her research interest and developing program of study include looking at opportunities for donation from the out-of-hospital environment and the role of paramedics in donation pathways. And with that, we're all excited, and I'll hand it over to you, Chelsea.
Thank you so much for that very generous introduction. I'm just going to share my slides here. Can you let me know that you see that okay?
Yes, very good.
Good. Beautiful. Okay, well, thank you so much again for that introduction. I'm very happy to be here. So thank you to CDTRP for the opportunity to speak today in the Research Connect series, in the RDOT series, but especially just, for the opportunity to be a part of the CDTRP as a trainee so far has been a really, fruitful experience for me. I attended my first CDTRP conference in December in Montreal of last year, and it was lovely. I met a lot of great people, and I've met some really I've made some really good connections so far. So I really appreciate the opportunity to be here to speak with you today. So we will move along. So first of all, I want to introduce myself. My name is Chelsea Lanos. I am an advanced care and community paramedic just outside of Ottawa. And so my primary role on a day-to-day basis is clinical. So I do a lot of community paramedic work. That is my full-time job, where I do a lot of chronic disease management in the community. In that, I do a lot of palliative care and end-of-life care. I'm involved in procedures like MAID. So I do a lot of that. And then also do some high acuity 911 response as well. So lots of resuscitation and cardiac arrest, which is kind of a nice segue into what we're going to talk about today. And if you were wondering what a paramedic was kind of doing in the organ donation and transplantation world and how I got here, I'll tell you a really quick story of how I ended up here. So before I became a paramedic, I just assumed that paramedics had a role to play in organ donation and tissue donation, and I just assumed that these pathways were written already and were actively being utilized by paramedics, kind of all over the place, including here in Ottawa, where I wanted to work. And I quickly realized that that wasn't the truth, that a lot of these pathways were lacking in Canada and in North America as well. So that really piqued my interest and kind of sat on the back burner for a little while until I went to a paramedic conference. It was a national paramedic conference here in Ottawa. And I was a relatively new paramedic at the time. So it was about 10 years ago, where I met somebody from the Trillium Gift of Life Network. And we had a really quick chat. And he kind of introduced this concept of paramedics being involved in tissue donation in the out of hospital environment, which I thought was fascinating. And we had about a 2-minute chat, and I said, we need to do something like this in our service. So I quickly found my chief paramedic at this conference, and I said, Mike, we have to do this. And he said, it sounds like we do have to do this. So you go on and figure out how we're going to make it happen. And that kind of, is where things started for me. And within a year, I was able to recruit some colleagues, and we ended up with a tissue referral program after out of hospital cardiac arrest in Renfrew County, where I work. And things kind of just took off from there. And I wasn't satisfied with, just pursuing tissue donation, although I want to underline that that's extremely important and valuable. But I just knew that there was more for us to do as paramedics, and a greater role that we could play from the out of hospital environment. So that kind of took off for me. I pursued a master's in science with a focus on the potential for UDCD, or organ donation, after out of hospital cardiac arrest, and hope that my program of research will kind of take me beyond that in the future. So that was a little bit about me. So we'll jump into what we're talking about today. So I want to do this in kind of a structured manner, but give enough time for some discussion. So the first thing that I'm going to do is discuss UDCD in Canada and estimating that potential. And I'm going to share with you, what we did in our research to explore this. We'll talk about some barriers and considerations to UDCD pathway implementation in Canada. And then we'll talk about some subpopulations and other pre-hospital avenues to donation briefly. We'll talk about the role of paramedics, or the potential role, or maybe anticipated role of paramedics in these potential pathways. And then I will turn it over to you for kind of an open floor discussion, because I am really eager to, utilize the expertise in the virtual room to see, how we might be able to move this forward in a reasonable way in Canada. So, excuse me, when I think about organ donation, and specifically UDCD, so I will be referring to UDCD, and what I mean by that is uncontrolled donation after cardiac or circulatory death. So this is a type of donation that occurs after an unexpected cardiac arrest, and in this case, specifically in the pre-hospital environment. So when I think about UDCD in general, this is kind of where my mind wanders. I think about this huge amount of puzzle pieces and a community of researchers and clinicians and allied health, and policy and stakeholders and in government. And I think about us, and I think about us sitting around a table trying to put this together. And one of the things that, I often open with when I talk about this is what, I kind of ask the audience, what do you think a paramedic is here to teach you about organ and tissue donation? And the answer is nothing. I'm not here to teach you anything. I'm certainly not an expert in tissue and organ donation and transplant and critical care. But what I can tell you, and what I'm here to share with you, is that I am a paramedic with lots of clinical experience, with the same passion that you all have, and the same passion that kind of brings you here. And I think that paramedics, or I'm going to try to convince you anyway for the next 20 minutes, that paramedics have an opportunity here to, really solve this puzzle. We're somewhere in that pile, and I'm here to convince you that we should be at the table. And not only should paramedics be at the table, but I think the system needs us at the table, and not necessarily me at the table. But I think that we need to be represented, because I think that there is a huge opportunity, and I've seen it firsthand, time and time again through my clinical experience. There's a huge opportunity for us to look at the pre-hospital environment and the people that we're not considering, um, and see out of those people who could be a potential donor and help us solve this problem. So that might be us right under there. And with that, I will continue on with this. So I don't have any disclosures. I want to thank my research team listed here on the left, and then my affiliations are listed on the right. So it's no secret, and you in the audience are no strangers to these stats, but there is a worldwide shortage of organs, and that has led in the rise in demand for these organs. And so, what that's really forced our hand to do is kind of explore additional organ donation pathways, typically or sometimes unconventional pathways. But our hand has really been forced to explore new solutions and new avenues because what we're doing right now just isn't cutting it. And so, one of those avenues or potential avenues is this concept of uncontrolled donation or UDCD subsequent to out of hospital cardiac arrest. And so the solution or this pathway is accessible and effective elsewhere. So places in Europe, specifically Spain is a world leader in this. They're doing this and it's working well for them. But this is not currently happening, pardon me, in Canada or in North America. So what we wanted to know is with all of these shortages, worldwide and especially in Canada here, could we utilize the out of hospital cardiac arrest population through uncontrolled donation or UDCD? And would it be a benefit? So it sounds like a great idea, but it's a pretty complex thing to implement. And before we do that, we want to ensure that we're pursuing a potential solution that's going to bring us, fruitful results. It would be really unfortunate for us to pour all of these resources and manpower and money into these pathways for it to really have no impact on what we're trying to do. So what we wanted to do first was quantify if UDCD could be a potential solution in Canada and a good one. And so that's what we did. And I'll share a little bit about that later. So, a few stats to kind of paint the picture. Again, probably not unfamiliar to you, but there's about 60,000 out of hospital cardiac arrests every year in Canada. And when treated by paramedics, so when paramedics attend and attempt resuscitation, approximately 10% of these people will survive to hospital discharge. So that is about 6,000 patients. So when you think about 60, thousand people, 6,000 is not very much. And if you do some quick math, you will realize that 54,000 people or patients don't survive their out of hospital cardiac arrest, despite paramedic involvement and good resuscitation efforts. It's still a large percent of people that don't survive. And currently, as it stands, these people, these 50,000 or so people, are not. Are not routinely screened or considered for organ donation. Now, in theory, some of them might be transported to the hospital. So we need to consider that. And they should, in theory, be screened or routinely screened and emerge for, excuse me, eligibility. But we know, and the research has shown that we don't do a really great job at this either. But I think the main takeaway here is that there's over 50,000 people in Canada that are dying every year, and a lot of these people are not being taken to the hospital, and we're not considering them for organ or tissue donation. So it's a big or potentially a big missed opportunity for us as a healthcare system. And I wanted to just underline here that a lot of when I say not taken to the hospital, paramedics will attempt a good resuscitation in the pre-hospital environment, but not every single patient is taken to the emergency department. So if we decide that a resuscitation has been going on for 30 minutes. They've had good quality CPR and advanced life support, measures provided to them, and there really doesn't seem to be any benefit. We will not continue that resuscitation, and we will not transport the patient to the hospital. So that's what I mean when I say that patients are not conveyed all the time to the emergency department. And research has shown us that anything beyond that 20-minute time clock really proves little benefit. So beyond 20 minutes, resuscitation is generally considered to be futile unless we think that there's a reversible cause, in which case we will transport. And to contrast all of that, there's about 4,000 people on Canadian transplant wait lists at one time. So a pretty significant number. And we wanted to know, out of those 50,000 or so patients that we are not transporting to the emergency department, how many of those could help us solve, the wait list, or at least alleviate some of that wait list. And so that's what we wanted to do. We wanted to estimate the Canadian potential in that population. We wanted to see how many of those 50,000 people could be potential donors that we were missing. So what we did to estimate this potential is we did a cohort study using the Canadian Resuscitation's Outcome Consortium, or CANROC, and this is a pre-hospital cardiac arrest registry that specifically looks at out of hospital cardiac arrests. And they prospectively collect data for us to use for research. So we used that database, and we took a 3-year chunk of data from 2016 to the end of 2018 to create our 3-year cohort. And with that cohort, we applied 5 sets of UDCD protocols that are used in practice internationally and in places that utilize UDCD pathways. And one of these was informed by a group of local subject matter experts. And now we can say that that was the recent ILCOR joint statement on organ donation, and the protocol that they suggested in that paper, which we will talk about. And so what we did is we generated a range of potential for eligibility. So a range ranging from worst case scenario to best case scenario. And the reason that we did this was there are so many different variances in UDCD protocols that are used internationally that we thought, only applying one of these would kind of limit us and really wouldn't give us a good whole perspective on what the potential could actually be. So we thought we would kind of pigeonhole ourselves by only applying one protocol. So instead, we applied 5, and we thought, or 4, and kind of a new one, but we thought that this would really allow us to generate a range of potential. And then we were pretty confident, or we could say with, a modest amount of confidence, that the true number, or the true potential number of donors or potential donors, would lie somewhere in that range. Might be closer to the one end or the other end, but we knew that the truth was probably somewhere in here, because you will see that the 5 protocols kind of vary with regards to what they look for and how they exclude patients. So we included all non-traumatic adult out-of-hospital cardiac arrest cases that we pulled from CANROC in those 3 years, and the cases that were treated by paramedics. So if paramedics were not involved, they were excluded. We excluded, our age range, was 18 to 65. So pediatrics were excluded in the study, and anybody over 65. And the reason that we did that was that most protocols will exclude anybody over 65 for organ donation. Any cases that had missing age data were excluded. Non-medical causes of out-of-hospital cardiac arrest, so trauma was not included here. And then patients that were obviously dead and therefore had not been treated by paramedics were excluded. And then that left us with a population here of just over 8,000 people, or patients, in those 3 years. And so that's the number that we used to apply our criteria. So this is kind of a busy slide. The next few slides are a little bit busy, so I apologize for that. But I will walk you through them. So these are the 5 criteria that we utilized. I'm just going to move that here for a second. So what I want to draw your attention to here is that we divided these into kind of 2 steps. So we looked at case characteristics for inclusion, and really what that was age, witnessed status, and time to CPR in the pre-hospital environment. And then the second step, so once we kind of excluded patients on the characteristic criteria, we moved along to the comorbidity exclusion criteria. So that would generate kind of a worst case scenario. And you can see here, I'll leave this up for a minute, but you can see that the 5 criteria have relatively similar case characteristics, but where things kind of vary are in the comorbidity exclusion. So some criteria, like the master criteria, is pretty flexible. They don't include or exclude a lot of people. But then you have something like the ill core criteria that's a little bit more calculated and who they are excluding, for example. So that kind of caused a variance in the numbers that we saw. So what we did first is we created or generated this best case scenario. So that was by doing step one and just applying the case the case criteria. So age, whether or not the out of hospital cardiac arrest was witnessed, and if the patient had CPR, um, within the more flexible one was 45 minutes. And then you can see the numbers here that were excluded, the cases that didn't meet those. And then that kind of generated our best case scenario, which was in the master criteria, given that it was a little bit more flexible than the others. And that generated a best case potential donor pool of just under 3,000 patients. So similarly, we did kind of the opposite, where we generated a worst case scenario. So I'm going to go back for a second. From the last row here, so from these numbers, we then moved on to step two, and we applied all of the comorbidities for exclusion. And then you can see here the total patients that were excluded. And then that left us with kind of our worst case potential donor pool, which was 621 in the Paris criteria. And I will kind of talk about it now, but what we did for these comorbidities, I have to harp on my profession for a minute, but paramedics are really, really bad at documentation. So we don't document very well, and we decided that it was probably not worth going through, 8,000 paramedic documents to kind of figure out, what these patients were coming in with. You can appreciate, I'm sure, that over the course of a resuscitation, specifically, paramedics are not super worried about, an extensive medical history beyond what is relevant, and things like medication. So we knew that that wasn't a very viable avenue to pursue. And so instead, what we did is we applied population estimates. And what that means is that we, for example, let's pick one. We took hypertension, for example, and we found a Canadian figure from a reliable data source. And we kind of, used that population estimate about how many people in Canada between, this kind of age range have hypertension. And we excluded based on that number. So for every different comorbidity that you see listed here, we found a data source that was Canadian, and we tried really hard to kind of even match it up to the time frame. So we did the best that we could, but acknowledging that this was a limitation to our study. And then that allowed us to exclude patients and then to generate a worst case potential scenario. So our best case scenario, again, was just under 3,000 patients. And what we did was we used a mean of 2.1 organs per donor, meaning that for every donor that we identified, or potential donor, we rounded down to two, you would get just over 6,000 additional organs that you could utilize to kind of address that wait list. And then what we did was we averaged that per year. So that's an extra 700 organs per year that you would be, potentially gaining from this population. Yeah, so that's what we did. And then again, similarly or in contrast, we did the same with our worst case numbers. So our worst case, in this case, our worst case is 1,300 additional donors, and then we kind of split that up on a year-to-year basis. So we divided by 3 because our cohort was 3 years long. So that would be 155 additional donors per year based on that worst case scenario. And then again, if you double that, you would get 326 additional organs from this worst case scenario in this pool. So it's a pretty large range, but like I mentioned earlier, we can kind of be confident, or we can be somewhat confident, that the truth lays somewhere in there. And again, we have to take, into account that these UDCD criteria or protocols are from a variety of places, so lots of variance in where they're applied and how they would be applicable here to Canada. But again, another reason why we chose to apply 5 instead of 1. So just a bit of a recap for these numbers. We have 60,000 or approximately 60,000 cardiac arrests out of the hospital in Canada every year. Only 10% survive while treated by paramedics or if treated by paramedics, leaving a considerable population behind. And then what we found is that we could generate in that 3-year cohort approximately 600 to just under 3,000 additional donors. And if you double that, you could generate 1,300 to just over 6,000 additional organs in that 3 years, which is quite significant. But keep in mind that you have to split that over 3 years. So again, some limitations to our study. So we have inherent retrospective study limitations to acknowledge. Although the intention or future intention of CanRock is to be pan-Canadian, so to have a true contribution from sites all across Canada, that's still a work in progress, moving along really well, but still a limitation. And at the time that we use the CanRock data set, only 4 provinces had contributed, or 4 sites had contributed from 4 provinces, being BC, Alberta, Ontario, and PEI. So truly not pan-Canadian, which only means for us that this is probably an under-representation of the potential that we might have here in Canada. So we would speculate that the numbers are actually quite a little bit higher if we had every site contribute to this data. And I hope that in the future we might be able to replicate this study with a larger data set. And then again, we didn't consider traumatic cardiac arrest, so that is also a limitation. And then we talked about the comorbidity estimates as being a limitation as well. So I'm going to kind of change gears for a second. So the ILCOR joint statement on organ donation, which was published in the fall of last year, states the following. They say that all health systems should develop, implement, and evaluate protocols designed to optimize organ donation opportunities for patients who have an out-of-hospital cardiac arrest and failed attempts at resuscitation. So this is the graphic that they use in their manuscript. And if you follow kind of the right side here, this is typically where that would go from the out-of-hospital cardiac arrest population. And so I think what I've done here is I've told you that we have a large amount of patients that we're not considering after termination of resuscitation, that we have the data to prove that there's probably some potential there and probably some urgency to consider this population. And now I've told you that ILCOR is saying, this is a really good idea, we should do this. So it kind of sounds like a no-brainer. But I think that comes with a really, really large caveat that we need to talk about. Not only a large caveat, but a very multifaceted caveat. There are a lot of barriers and things to consider for potential implementation of these pathways in Canada. So the first thing that we need to consider is paramedic education and scope of practice. So I kind of alluded to this in the beginning in saying that if these UDCD pathways were successful, paramedics would have to be involved. They would have to be involved from a identification standpoint, resuscitation standpoint, and then transport standpoint, of course. So part of this greater multidisciplinary team to make this happen. And with that would need to come a lot of education around organ donation and tissue donation practices, scope of practice regarding the administration of, some medications or some procedures that wouldn't be necessary to pursue UDCD pathways. So that in itself is a fairly large undertaking. We need to talk about ethics. So we need to talk about, things like ongoing resuscitation or prolonged resuscitation of patients for the purpose of organ donation, and whether or not we believe as a society of, is this ethical? Is this ethical when we consider things like consent or lack of consent if there is no family or person there to provide that consent? We need to talk about logistics. So we need to talk about things like, time to hospital, and not only just hospitals, but organ transplant capable centers. So perhaps a UDCD program would not work very well in, a super rural service or part of Canada, such as perhaps the territories who don't have as many resources as some urban centers, like Ontario, for example. And then we need to talk about things like medical legal considerations. So things like consent and the legislation around consent and what that means for provinces and what that means for Canada, who is, largely a opt-in country when it comes to consent for organ donation. So there's, one province, Nova Scotia is an opt-out system now. So that would alleviate some of those considerations, but the rest of these kind of still stand. So lots of things here to consider, lots of barriers, and each of these could really be expanded and developed. And we really have to look at what other systems in the world are doing to kind of, alleviate these or address these, if you will. So this is kind of a good segue into talking about things that are maybe a little bit less ethically complex, or complex, or less ethically complex, and are ethically complex in different ways. So, for example, if we talk about, so we've talked about UDCD. If we talk about tissue donation, it's important to acknowledge that tissue donation is a little bit easier from an ethical standpoint, from a logistics standpoint, because the tissue doesn't need the same sort of perfusion or blood flow to provide things like oxygen, like solid organs. So tissue donation buys us a little bit more time. It buys us more time to have conversations with families. It buys us, more time to transport. So things like logistics are a little bit less time sensitive. We have quite a bit of time here to address this. Um, and then we kind of take away that whole ethical piece around prolonged resuscitation because we can provide, or we can pursue tissue donation with patients who no longer are being actively resuscitated. So we can terminate the resuscitation and then go ahead and pursue tissue donation. And we have a pretty flexible time frame to do that. So this is happening in Canada, just because it is a little bit more, it's a bit easier with regards to things like ethics and logistics, and paramedics are involved in this now. So that is good news, and perhaps that is a program that needs to be expanded in Ontario and in Canada. The second thing we could consider is something called NPOD, or non-perfused organ donation. So I just told you that most organs, or all organs, need to be perfused, meaning that they need blood flow, and that's why we need to prolong resuscitation if we think somebody is going to be a potential organ donor. But there is this new practice of NPOD, which again stands for non-perfused organ donation. And the name kind of implies that we can still pursue organ donation in somebody that is being not perfused. And this has only taken place, from my understanding, with the lungs and nothing else. So a bit more flexibility there with our time frame. So again, alleviating that need for prolonged resuscitation. So NPOD could be a little bit less ethically challenging, morally challenging, and give us a bit more flexibility with logistics. And then the last thing, and I'm not going to expand on this today, but I think it's important to acknowledge that, we're seeing, a lot more palliative and end of life care in death in the community. And, a portion of those people are choosing MAID, or medical assistance in dying, to end their life. And a lot of these patients are asking about MAID. Now, I'm not an expert in this field. There are, incredible people doing really incredible work in Canada with regards to organ donation after MAID, in our network, and we'll see kind of where that goes. But I think that needs to be acknowledged that paramedics, have been and might have a role to play in this population. So would be a little bit less ethically challenging because all of this would kind of be a little bit more controlled. So whether or not we're still coining that to be uncontrolled donation, I think it would be, a bit more controlled and pre-planned, and has been in the past and has been successful here in Ontario. So I'm going to move along here. So to kind of recap, I've told you that we have a massive organ shortage, and we have this large population that we don't routinely consider for organ donation. And so there's immense potential there for UDCD, and that's supported by, the people like ILCOR. Um, we've talked about a potential role or supportive role for paramedics alongside so many other professionals. And I think that this could truly lead to systemic change in Canada. So we talked again about the role of paramedics and what that might look like, and I think a lot of this is still kind of unwritten. When I think about a role for paramedics, I kind of split this up into three different pieces. I think about donor recognition and identification. And perhaps having the ability to refer to a specialist team or a transplant team over the phone for consultation, and then a decision could be made with allied health, and then we would pursue things like resuscitative measures that are necessary for organ transplant, and then of course our role would still fall within transport. So that's something that we still need to unpack and think about, and consider what paramedic roles are being undertaken elsewhere internationally, and how those are successful. So something to really think about. So to kind of wrap this all up, um, a bit of a look ahead. So what we'd like to do as a research team is look at sub and special population estimates. So perhaps replicating this study with a larger cohort, and perhaps limiting the application of our criteria to the ILCOR criteria because it is relevant here in Canada, along with other populations. We should quantify the potential for NPOD and for tissue specifically. So again, a similar type of study, but really looking at those two populations and how we might be able to leverage those. We need to do some work around economic, legal, and ethical analyses and what impacts that would have here in Canada. And then I think, kind of the tail end of this is defining pre-hospital pathways, including roles for paramedics, and eventually piloting this UDCD pathway after OHCA in Canada. So that's kind of where we anticipate this moving along in the future. So I'll kind of leave you with that, and I will hand it over to everybody else. I'm happy to take any questions, but some questions here just to kind of guide our discussion, or maybe frame our thoughts and discussion. So what are your thoughts around UDCD in Canada? Do you foresee any barriers with this, or do you foresee some benefit with these potential pathways? And then we should talk about other considerations, and maybe we can expand on clinical considerations and ethics and legislation and morality and those things. And then I would be really curious to know if anybody has any thoughts about research priorities moving forward to explore this further. So thank you for your time, and I'm really looking forward to some conversation.
Thank you, Chelsea. That was very, very nice. And I guess anyone would have any questions for Chelsea or any comments you would like to share? Feel free to go ahead or raise your hand, or even write it in the chat. I think I do have one question. You mentioned that this practice has been done internationally, and I guess one question I had is if would you have any idea on the success that the other countries have had in the in I guess donation after cardiac arrest out of hospital?
Yeah, it's a great question. I don't have the exact numbers, like I can't quantify the potential right off the top of my head. We intend to do a bit of a scoping review in the future just to kind of see like who's been successful, and for what reasons. Spain is kind of the world leader, has been the world leader to date in UDCD, so I would probably defer to looking over there. I don't know if there are any clinicians here that are familiar with UDCD. If you do, please go ahead and chime in. But yeah, truthfully, I'm not sure, what the actual quantified success is there.
Okay. Okay. No, thank you, Chelsea. I think Nicholas has a question.
Hey, thanks for that great talk, and thanks for doing this work. It's really interesting. Um, I guess one question I have for you, or if anyone else wants to comment, is I guess it's a legal and ethical question, but the inclusion criteria I've seen for UDCD versus ECMO for rescue are quite similar at times. Um, and I just wonder how you envision the protocol actually happening in real time. So would it be the paramedics themselves who are transitioning from attempt at rescue to organ preservation for preserving the opportunity to donate? Or would it be another team, specifically a UDCD team, that sort of gets things handed off to? And if the former, as a paramedic, do you see paramedics being uncomfortable maybe with that decision-making responsibility? Or whether it even might introduce a conflict of interest that might be problematic from their perspective?
Absolutely. Thanks, Nicholas, for several questions in there. So I'll do my best to address them. I think paramedics will definitely have a role, and that role, again, is still fairly unwritten. And I think we need to, as a research community, kind of figure out what that looks like for paramedics, and at what point we switch from resuscitative measures to, life-preserving measures for the purpose of organ donation. And we need to figure out what point, if any, where that is ethical, right? And where paramedics feel comfortable. And I think that that exceeds the current or the average paramedic scope, and we would need to lean on an interdisciplinary team, or transplant team, which is the reason I kind of suggested maybe we have an on-call team that we can consult with at a certain point in our resuscitation to say, this is where we're at, this is the patient that we have, and we've identified them as a potential donor. What kind of options do we have? Do we have a specialized UDCD team that we can activate? I think if that team was made up of paramedics, they would likely be critical care paramedics, and we could utilize the flight system. I think from a logistic perspective, that would probably be more feasible, unless paramedics were in an urban center where they had access to transplant centers within a few minutes, where they could package the patient and continue on with the resuscitation without really interrupting that potential. Um, and do I think paramedics would have a hard time with this? I do. Um, I do. I obviously am very supportive of this, but I think the average paramedic might have a hard time wrapping their heads around this, and being uncomfortable with the ethics, and just, yeah, the ethics of pursuing and approaching families about having and having consent discussions. I think that is really lacking in paramedic education. So something that would need to be addressed from like a foundational standpoint to make sure that paramedics were equipped with the tools that they needed, to be able to be successful in a role in a system like this. So hopefully that answers your question.
Yeah, that's a great response. I'll just quickly say I really like that idea you have, like, even if the resources aren't there, to have an independent team that shows up on site or meets halfway, having sort of a team uh, with which the paramedics could communicate and um, make the decision together based on what's happening with the patient seems like more feasible solution, and also probably would make everyone more comfortable.
Definitely, it would shift the onus from the paramedic to a specialized team, with a larger scope of practice and more clinical oversight, for sure. So yeah, I think we have a lot of work to do and things to consider. And one of the things that we intend to look at as a research team is to see what practices or how this has been navigated elsewhere internationally, and how paramedics have been involved, and in what types of roles, and how they've encountered some of these barriers. So lots of work to do there.
Would anyone else have any questions or any comments? Chelsea, I was wondering because you Nicholas and yourself mentioned, I guess, the roles of the paramedics, and I was kind of wondering, I guess, for paramedics to be involved in this, what kind of training would they need to have? I guess beside from what they already have now.
Yeah, that's a great question, and I think the answer to that is kind of twofold. I think we need to consider, education, like foundational education about organ donation, and approaching families with consent and like hard conversations around resuscitation and potentially futile resuscitation, and shifting our efforts, and not to have families come back and think that there's a conflict of interest. I think this is really ethically saturated and really difficult for paramedics to navigate. So I think on one hand, the additional training would need to come in the form of education around all of these things, and then I think the other side of that is really clinical. And for those of you that are not familiar with paramedics kind of in Canada, there are different levels of paramedic practice in Canada. So you have your primary care paramedic, your advanced care paramedic, and your critical care paramedic, which you usually see in the flight system. So the critical care paramedic is actually a specialist in interfacility transport. So, monitoring everything that you would see in an ICU to really move patients. So I think from a clinical perspective, the critical care paramedic would probably be the most suited, for perhaps a specialized team. But I think that clinically, you do have paramedics at the advanced level that could, facilitate things like intubation and ventilation, and some of those things that we need to do to to ensure that transplant might be successful from like a clinical standpoint. Um, so I think, yeah, again, the answer is twofold. It comes in the form of education and also on the clinical level as well.
Thank you, Chelsea. I see Adam has his hand raised.
Thanks, Chelsea. This is fantastic. I really hope that our profession gets to move forward with something like this. I think the work you're doing is really great. One of the things I was going to point out, you kind of already mentioned in your last answer, is just the different levels across Canada. And so the standardization would have to be quite significant. In Alberta, we don't have critical care teams. All of our paramedics in Alberta are considered advanced care paramedics, but are actually trained to critical care levels in other parts of the country. We start looking at interior BC, where that's the only place that they have advanced care paramedics as opposed to most rural sites. Do you know that when you were looking at your numbers and your inclusion criteria, was it just patients who received advanced care or advanced care life support, or was it basic life support inclusion as well?
I think they were both. I don't think that there was a variable, and I could be wrong, but we didn't consider a variable if it existed of whether or not they received BLS or ALS care. But that is a really good consideration, to take into account for a future repeat of a study like this, because I think it's an important variable to consider. Um, when we talk about switching from resuscitation to life preserving measures for the purpose of organ donation, and how and what care we've provided to that patient to ensure that we're not switching prematurely to pursuing organ donation.
Thanks so much.
Thank you.
I noticed in the chat there's a few comments have been made from Donna, and she has mentioned that just a comment, more food for thought, organ and tissue donation pathways. Why could we as Canadians not choose to explore these pathways? And that she mentions that we have more to consider. And Fiona has mentioned, I guess, to Nick's comment. Conscientious objection is sure to play a role in this, which may suggest a second approach would be more beneficial as to reduce this risk.
Yeah, thank you to both of you. I think, yeah, we do have a lot to consider when we talk about, all of these different pathways. And thanks, Fiona. Thanks for being here. But I think that shifting that onus from paramedics to specialty teams that we can work with, as opposed to, putting all of this decision making on paramedics who truthfully are not educated enough to be making these decisions, both clinically and just with regards to, things like ethics and, as it stands with the current curriculum. So thank you for that.
Nick, go ahead.
Thanks. I see that somebody else had a comment, and I don't want to hog the question period, so you can come back to me if there's time.
No problem. Jehan has said, asked the question, what do you see as your next steps and with this work?
Yeah, so great question. So I kind of alluded to the fact that we were going to pursue kind of a scoping review. So the next step for the next project we have in mind is a scoping review of UDCD practices internationally, plus or minus, the specifics of the paramedic role in those pathways. But I think we need to do a better job to quantify UDCD potential. So our numbers are promising, but again, coming back to that limitation of this not being, truly pan-Canadian, which is the intention. Perhaps we could go back to the CanRock data set or combine that with another data set that's available to really try to hone in on, a more accurate potential. So that on one hand is something that we're considering along with subpopulation potential, like potential for tissue donation and NPOD and things like that. But then we also really want to look at UDCD practices worldwide and see where they've worked and how they've worked and what kind of systems were in place to make sure that they were successful and see if that can be applied here in Canada with within the limitations of our system, whether that be logistical limitations or legal limitations or that kind of thing. So there is a lot of work to do, and I don't know the whole answer to that question. I'm doing a very small part of the overall research in this field, but I'm looking forward to working with other people to see where we can take this.
Thanks, Chelsea. Going back to you, Nick.
Sure. Yeah, it's kind of just a narrower question, and maybe Chelsea or maybe one of the clinicians on the call could answer it. But I'm just wondering about the death determination guidelines for Canada that were released last year, and how UDCD might interfere with death determination in the field. Because if you were to institute ECMO in the field following failed resuscitation, you'd be invalidating the criteria on which the death determination was originally based, because you'd be recirculating blood without any prevention of brain blood flow. So would it actually be that the patient is not determined dead in the field and then death would be determined on arrival in hospital? And I guess I'm just wondering how it would work. I guess I'm partly worrying whether we've shot ourselves in the foot with that guideline too.
Yeah, it's a great question. Truthfully, most of that question is kind of beyond my expertise and like clinical knowledge. But I think it poses a really interesting question as to, our paramedics can't actually declare death, but we can declare an unsuccessful resuscitation. At which point the coroner typically gets involved, or at least that's how it works here in Ontario. I don't know. I think that's a really interesting question, and we need to consider things like whether or not there was a return of spontaneous circulation, because then those patients are transported, and that donation pathway now becomes, it probably goes down the brain death pathway. But your question about ECMO is really interesting, and I don't know the answer, but if anybody on the call has any thoughts on that, I find that really interesting, and I'd love to hear.
I think that maybe the problem might be obviated by what you said about death not being declared in the field. Mm-hmm. Because if you were to put ECMO, the patient on, or the potential donor on ECMO in the field, and death determination was delayed until they were assessed in hospital, then I don't think it would probably necessarily problematic.
Right, and that's how it would work here in Ontario. I'm not sure about other provinces, but paramedics in Ontario can't formally declare death. We can declare an unsuccessful resuscitation and have orders for termination after that point, but the coroner is typically still involved.
Okay, thanks.
Mm-hmm.
Now I can speak a little bit to Alberta. So again, protocols here are after you run down your ACLS kind of algorithm, You determine whether or not it's again, I guess a successful or unsuccessful resuscitation is probably the best term. But there's no one that you're calling. We actually have the right or the ability to then say all resuscitation efforts have ended. And we turn then the body over to the police service, and then they then will coordinate with a coroner and decide for autopsy or not, if it's expected death, that sort of thing. But for the majority of the time, the only time that we actually transport anyone would either be if you get a ROSC or a significant change in rhythm. So if you're going from kind of that VTAC, VFib back and forth between a PEA back to VTAC, VFib, then there's some protocol change in there. But other than that, if you work a cardiac arrest for between 30 to 40 minutes on scene, you have the ability to call that at that point in time and cease all resuscitation efforts.
Thank you, Adam. I think the time is just about up, and well, thank you everyone for the questions and comments, and thank you, Chelsea, on behalf of the CDTRP. Thank you for a great presentation. And if anyone has additional questions or comments or suggested topics or speakers, contact Erica Croft at EK Croft CROFT at cdtrp.ca. And I want to mention that all participants will receive an email asking them to fill out a survey. We would appreciate it if you could take 3 minutes to complete it. Doesn't take very long. And so thanks everyone, and enjoy the rest of your day.
Thanks everyone for being here.